Yeah, I'm excited to get to talk. I always get nervous when I get to talk, and so I'm like, oh, good. This is a very friendly audience, and so hopefully it'll be a good conversation. Um, but a few months ago, um, our friendly sweet Kim says to me, "Hey, can you just teach our group how to become an MOUD MAT prescriber?" I was like, "Oh, sure, I can do that, Kim. I'll be glad to. I know where this website is." And I said, "Now, Kim, I'm going to have to do a little bit more research because I did get board certified in addiction medicine, but it was in 1994. And OxyContin didn't even exist then. A lot has changed." I said, "Well, I'm going to have to do the 8-hour training, Kim. So that's going to take a lot of work." She's like, "Good, go do it." So, I did what I do, which is I started reading and I saw, oh, in family medicine, they're talking about this in September 21, they're talking about prescribing buprenorphine in family medicine practices and how rewarding it is. I started doing research around behavioral health integration in OUD. And there's definitely research, and it's being published last year in PCBH model, collaborative care model. So I was really like, okay, this is great. And I started going down these rabbit trails and seeing all the data, how many overdose deaths we had last year. And even looking at the comparison over the since the pandemic, and showing that we've had more deaths, and Arkansas is higher at 32.9 compared to the average. So starting to get really motivated and seeing, wow, there's going to be a lot for me to be able to talk about, and no problem, I can do it. The 7 Days documentary, I saw that, we talked about it. If you have not seen it, that should be the one thing that should be your New Year's resolution. This is outstanding, and it really puts context to our consortium and to our grant. So I started continuing, and then the news came out in 2019, there was 72,000 overdose deaths, went down. It says 17. But anyway, 21, there were 100,000 in the same time period compared to 2000. So it got better for a while. I think this probably needs to be 71, but anyway. So is that right?
71. Yeah.
So you see the numbers are just, yeah, there's 70,000. The numbers are overwhelming. So yeah, we need to do something about OUD. We need to do something about addiction, opioids. And, my husband's been away doing a travel nurse job. And so I had plenty of time. Somebody said, "Have you watched the series on, Dope Sick?" And I was like, well, maybe I'll check that out. There's one called The Pharmacist about actually a doctor and a pharmacist down in New Orleans, where my husband's from. I started watching all of these series related to the OUD epidemic and the opioid epidemic. I got the book out on the Sackler dynasty and the people who were part of Purdue Pharma and creating OxyContin. And I got really disturbed by all the corruption that's in so many parts of our society and in medicine and FDA, the DEA, and how this opioid epidemic happened. And then even looking into the age of addiction, David Courtwright actually uses a term called the limbic capitalism in terms of how businesses are taking advantage of our brain. So this is basically about how I began to start feeling. I was so overwhelmed with so much, and I would follow these rabbit trails and get so excited about what I was learning. Excited, horrified, but also inspired that we've got to do something. I've got to do something. And so then trying to think of what to teach. So I had to find some sort of peace. So this is me a few weeks ago when I went out to visit Tommy outside of Las Vegas, Nevada. That's at Red Rock Canyon. So I was like, okay, get me away from all of that reading and immersion. And so I flew out there, and I began to be thinking about a map. how do we get places? And I began to think about the map of our consortium and our education process of where are we trying to go? Because there's a lot of places, it's a 3-day drive over to Vegas, and there's a lot of places that you can kind of get off and start exploring. And that's what was happening with me, as I was just trying to think about what would be useful to teach. You know, when people are going to Vegas, this is pretty much what they're thinking, and this is what we saw downtown. It's definitely the lights and so much to do there, and that's along the path, and that's one place to go. But also another place that we saw was going on this road, and this is Red Rock Canyon in Calico Mountain, and this is right outside. There's a casino right there, and we're like, oh wait, this is a different part of Las Vegas. We did some hiking, and this is us going up into this Red Rock Canyon, and there's some serious rock climbing that happens there. So you outdoors people, I know that some of you like to get out, and this is a great place to go. And so that's how I ended up getting to my little quiet place, and it was just so much fun to get outdoors. And so just thinking about that, of the map of how can we get where we want to go in this learning times, because hopefully we will continue to have some education around not only opioid epidemic and OUD, and deciding what we want to do about MOUD and buprenorphine, but there's a lot of other things involved along this journey that are going to be important for like the Dr. Lofton and his clinic, but also for all of us who are involved in the consortium and in the work that we're doing. And I see Gina, glad to see you there. But everybody knows KSAs. If you've been a supervisor, or if you've been an employee, you've had your knowledge, skills, and attitudes assessed. And what I really want us to start with on this journey is our attitude. And if we are gonna do some knowledge today, but instead of being knowledge, skills, attitude, we really need to go to the foundation and be thinking about our attitude. And so that's what I want. If there's probably about 3 things I want you to take away from today. And one is that we have got to start with our attitude and with stigma. And some of the pieces of this is, so who are addicts? Who becomes addicts? And why does this matter to me? Why does this matter to you? Why does this matter to you as a person in our society? Why does it matter to you or me in our healthcare system? Which patients does it affect? And how are we going to approach it? And the good news is there are a lot of treatment centers and treatment. But the thing that in my exploring that I've come to is the way we've got to approach the opioid epidemic and addiction is with patient-centered care, with team-based care. And we've got to approach every patient. And I'm going to show you a little bit why. And patient-centered care, you know, I've learned a lot from some of our peer specialists, and I spent some time talking to, gosh, I'm drawing a blank on his name, Kyle Brewer. And I said, Kyle, what does a doctor need to know about addiction? And he is the one that started talking to me about patient-centered care. I expected him to tell me about what meds that we need to be able to be prescribing, but he was talking about approaching people as people and as persons. And you know, when I hear that, I've often thought, well, of course, I always approach all my patients as a person. All this person-centered care thing, but it's starting to dawn on me, especially as we're talking about addiction and especially OUD, because the stigma and the way that we've separated out not only mental health and behavioral health, but separated out substance addiction and mental health. But the other thing, the word and the attitude that I want us to end with is hope. So as overwhelming, and we've seen all those numbers, I want us to leave with some hope. And the science gives us hope. So some of the knowledge we're going to talk about, I'm going to go into defining addiction. We're going to look at how substance disorders are diagnosed. We talk the brain reward pathway and a little bit of tools for today. We will be getting to skills. That'll be on our pathway. So stay tuned. And this is a 3-year grant, but you might find some places along the path. So if you need certain skills, there's so much we can do. We're drinking out of a fire hose. So you're going to need to let us know which skills do you need. There's some that we think we all need, and we'll be bringing those. But so skills will be coming, but we're not going to focus on that today. So who is affected by addiction? Who becomes dependent on something? This is one of the slides to remember. Nature, nurture, neighborhood. Nature, nurture, neighborhood. So which is more important? Well, all of them are important. Nature, what we mean by that is your genetics, your body, your physiology. Nurture, where did you grow up? What type of environment was your family? What were your social, and what neighborhood were you in? What were you exposed to? The PCSS, this is the website that has so much information about Suboxone and addiction in general. But they just divide it into genetics and environment. So genetics, it's not like you have a gene that's like blue eyes, brown eyes. The genetics for addiction are complicated, and they have to do with the receptors, but they also have to do with personality. People who have novelty seeking, people who have impulsivity, and then psychiatric disorders. Very strong genetics in this disease, very strong. They did research in families, adoption studies, very strong. Environment is huge. Who your parents were, not just the genetics, but what did they go through? Adverse childhood experiences, ACEs, any trauma, not getting good positive experiences. But then did your environment give you opportunity to use any substances or behaviors? Did you get that prescription for pain medicine? So nature, nurture, neighborhood, that's who becomes addicted. So this is another thing to take away. What is addiction? Continued use despite negative consequences. If you want to just remember one thing, and we're going to go into all the criteria to diagnose it, but if you're just trying to figure out, well, does somebody have a dependence or an addiction, just ask, is there continued use despite negative consequences? This is nothing about how many beers they drink, how many cigarettes they smoke. It's about, are they doing something that has negative consequences for them and for their family? And we'll go into some of the details. Definitely there's some compulsive part to this. There's craving for some people, but sometimes people will say, no, I don't have any craving. I can't be addicted. For some people, there's physical dependence and withdrawal symptoms, but for some people, there's not. So these are not required for a diagnosis, but just continued use despite negative consequences. The other thing, like a lot of things in medicine, is to think of things as a continuum. Most people do not have substance use issues. And then the next largest group are low risk. Then we start getting into unhealthy risks, unhealthy use, at risk, harmful use. And although this says alcohol, this can be applied to any substance and any behavior. So there can be heavy consumption and then looking at consequences. This is another slide. In a way, we often will give, we'll say this, but I don't know that a lot of us really believe that addiction is a disease. We're still dealing with, this is a moral failure, and there's some internal judgment that I know that I probably continue to have, but I'm making progress from where I was. But if you look at disease compared to other chronic conditions like depression, diabetes, hypertension, asthma, all our quality measures around all this, but really addiction is just like these. There's similar treatment adherence and relapse. You know, you have a lot of diabetics and hypertensive and asthmatics that don't take their medicines like they're supposed to. that continue, their disease comes and goes. They do seem to have some voluntary control and impact on their disease. These things are difficult to manage behaviorally. They all often have a genetic component. They do respond to treatment. And some people really do have to have a lifelong management of that condition. So addiction is like that. Substance dependence is like that. But the diagnosis for addiction, it is based on behavior. And this guy, there's some good videos that he's given. So I've got some screenshots from his YouTube videos. But he says, it's behavior. Why do we get upset when we see someone who has a substance dependence problem and they're doing behaviors? They're acting in a certain way. Well, that's how we diagnose it, from those behaviors. In medicine, and when you are on your charts, or when you're working with people where you're needing to get their diagnosis in the chart, the DSM diagnoses are what we use. Some people call this the psychiatric Bible. It's not our Bible, but it is the 5th version, and I think there's a new one coming out this year. But this is where all the diagnoses are listed, and this is where insurance pays, and the way that diagnoses are made from a medical standpoint. It has substance use disorders and substance induced disorders. There are 10 classes. There's intoxication of any of them, withdrawal, and then they may have you may have alcohol-induced anxiety, alcohol-induced depression. And notice caffeine is one of the substances that is in the DSM. Also, it has other or unknown, and it includes gambling. So that is a behavior that's in here, and that was the first behavior to make it into the DSM. So looking at all those classes of substances, we're focused on opioid use disorder in this grant, but we have to pay attention to all substances and behaviors. They're going to be part of sex addiction is, we'll talk about that, Jenny. So that's a good point. Sex addiction is not necessarily in the DSM at this point, but someone could put a diagnosis of that in a chart if they needed to, and use other or unspecified. But we have all of these different abused drugs in the United States. Now, this is a really busy slide, and I could spend a whole, probably 3 hours on the pharmacology of meds, but I want you to get the idea that there's different classes of meds. And this is where the DSM is correlating these classes. Now, one error that I see, CNS depressants, it has Prozac on here as a depressant. It's an antidepressant. And I'm not sure why they put that on there, unless this looks like it's a little cheat sheet for somebody in the ER, because it's describing what someone looks like under the influence, and then it's describing pupils and temperature and all that. But just to look at alcohol, Valium, Xanax, Soma as a muscle relaxant, and GHB and Rohypnol, depressants, stimulants, hallucinogens, dissociative anesthetics, so PCP and ketamine, cough medicine, it's in the same category as PCP. Oftentimes people will think narcotics means all of these, and then it could be that, say, in law enforcement or other places, they may use the term narcotics, but in medicine, we are usually meaning opiates when we say the word narcotics. I haven't heard much about inhalants lately, but when I was doing psychiatry, we had quite a few patients that would end up being admitted with abusing inhalants, and in adolescence, that can be a big thing, but also in certain populations. The Native American population in Mississippi had a lot of inhalant abuse. Cannabis, all these different formulations of cannabis. So those are the categories, and in DSM, they are going by categories. For DSM criteria, it is going to be severity. When you're diagnosing something in the DSM, you're going to say the severity, moderate, mild, moderate, or severe. the name of the class, alprazolam, alcohol, cannabis, a use disorder. And the important thing about this is, as you're having to get your HCC codes and complexity of your patients, this is when it could get picky as far as wanting to get the diagnoses correct. But I think it's important for all of us, even those that aren't working in healthcare, to understand how these diagnoses are made. So from the DSM, remember, 2 to 3 symptoms are mild, 4 to 5 moderate, greater than 6 are severe. The symptoms, there are 11, and they're in these categories of impaired control, social impairment, risky use, and the pharmacology. Remember, it's continued use despite negative consequences. So impaired control, do they take more substance in a larger amount than what they intended? Are they persistent desire to, or unsuccessful to cut down? A large amount of time spent is their craving. So that's impaired control. And somebody might have one of these in each category, or they may have almost all of these and get up there to severe. And you can see it doesn't take much to meet the criteria for, say, a mild alcohol use disorder. Social impairment is their recurrent use that's leading to failure to fulfill major obligations. Continued use despite negative consequences. So you could see if somebody had a certain diagnosis, diabetic, or some health problem, they may not need to drink at all. So 1 drink a day or 1 drink a week might be negative consequences for certain people, depending on what their health is. Giving up certain activities. Do all their activities revolve around the substance? Then risky use, driving, working, and continuing to use despite worsening consequences. Pharmacologic has to do with tolerance and withdrawal. Not every person goes through withdrawal. The withdrawal is usually the opposite of the intoxication. So whereas a CNS depressant, they're going to get calm and more relaxed, the withdrawal is going to be more hyper, higher blood pressure, shaky, the opposite. Whereas somebody that's used a stimulant, their withdrawal is going to be more of feeling lethargic, sleeping a lot, the opposite. Tolerance is a pharmacology term that means someone needs more to get the same effect. And actually recently we were talking with Josh Ramsey, one of our peer recovery specialists, and he was describing, he said, crystal meth, you can use the same amount and get the same effect for a long time. They don't have to increasingly escalate their amount. Compared to someone who is using an opiate, clearly opiates cause a lot of tolerance. So what used to give them a euphoria, they're going to end up taking more and more and more. And I forgot how many hundreds of pills he said he ended up taking. But you can even see this when people are young, 1 or 2 beers gets them a little bit intoxicated, and then it may take 6, and it may take a case. It may take, so tolerance, just what happens in our body. And I'm going to go through a little bit of the pharmacology on that. So why are certain substances more addictive than others? Why? The thing that has really gotten us on opiates, I was talking to Kyle, like, why are we so stressed? Why are we so focused on opioid use disorder? It has to do with the deaths, especially now that we've got fentanyl and people are dying right and left unintentionally. So this is part of what happens. So when someone is going to use a drug, the effect is in the brain. So if someone injects a drug into their vein, that it's going to go through into their right side of their heart, through their lungs, out the left side of their heart, into their brain. The red line shows you how fast that's going to happen. If someone smokes something, they inhale something, it's going to go into their lungs and then out the heart and straight to the brain. The thing about the lungs is that the lungs are filled with all of these blood vessels, so they can get intoxicated and get the effect very, very rapidly. So that's part of why inhaling, sniffing, snorting, smoking a cigarette, that the effect is a lot faster than, especially compared to if you take a pill. So you take a pill, it goes down through the stomach, and it's going to go through the intestines, then it hits the big liver here, which is going to do a lot of the metabolizing. And there's actually a thing, first pass effect, that's going to eliminate a lot before it ever even gets to the heart, and then up to the brain. So that's why for taking pills, it's a lot slower. So that is why as people's need more and more, they end up starting taking pills, and then they end up crushing them or finding a way to snort them, because then you get a faster effect. It's going to go up faster here. And then the other thing about it that can make it this is the pharmacokinetics. This is another, we could talk for an hour on this, but for you to see that what makes certain drugs more addictive is how quickly they get to maximum effect. And then, surprisingly, how fast it wears off. So this is, a lot of people in the past, they started using, powdered cocaine. A lot of people didn't get hooked on powdered cocaine. They could use it, did sniffing it. It went through the blood vessels in the nose and then to the brain. But there wasn't as much addiction when people started smoking crack. Very fast onset, very fast offset. So crack cocaine, it's the pharmacology and the way that the cocaine is created or exists is what makes it so addictive. This is the other thing. There's something about Xanax, like compared to Valium or Ativan or other benzodiazepines. It has a very fast onset and a very fast offset. And so that's going to tend to make it a more addictive drug. Gosh, I knew I was not going to have as much time as I would want. I see it's 11:37. Does anybody have any questions about this pharmacology piece or the DSM or the diagnosis? Okay. So as I kept reading, Dr. Judd Brewer is an addiction psychiatrist. And so I came across his information. He's an addiction psychiatrist at Yale and at the VA, and has done a lot of research doing functional MRIs and looking at people with substances. Well, he talks about we all struggle with something: anxiety, eating, smoking, shopping. And he breaks down the reward pathway, like we were talking about Jenny's cat. And what I've screenshotted some of his little videos and got his website. I really recommend that you find this. I've started using some of his techniques for myself. But what he says, we're all addicted to something. And heroin or opiates, food, drinking, running, Facebook, we all get addicted. Now, what does that mean from his perspective? For sure, this could have been me. I was addicted to Diet Cokes. I know in August of 2015, I had my last Diet Coke because a doctor finally said it's impairing me. So I know I was addicted to Diet Coke. We know people addicted to gambling. Well, there's also this book, and New York Times had a great article about food and how the food companies have put in salt, sugar, and fat, and how they are causing similar changes in our brain that opiates. And I'm going to get to that here in just a minute to show how that happens. So the DSM itself only has gambling in it at the moment. It doesn't have other behavioral addictions in there, and that's based on the evidence. The DSM is very much about evidence-based and research, but the next version may have something. So if you're treating someone in your clinic, an insurance company may or may not pay for sex addiction, food addiction, but with food, you may be able to end up putting it under eating disorder. But I do think that these other behaviors fit. So a couple of the books that I also found, Anna Lemke is another addiction psychiatrist, and she wrote this book on the dopamine nation. Dopamine is a secret to why things are addictive. She also wrote this book called Drug Dealer MD, and this, Dr. Lofton, you might enjoy this, how doctors were duped, how patients got hooked, and why it's so hard for us to stop. This is another great discussion, and why are so many people have been prescribed opiates. But anyway, Corey Waller, he's got some great videos, and he said human beings need 3 things to survive: food, water, and dopamine. Dopamine is what gives us motivation. We often hear dopamine is the pleasure chemical. It is about pleasure, but what it does is it motivates us to go do something that feels pleasurable. So this is a very simple drawing of the brain. Most of you probably know, but this is a half of a brain looking at it from the middle. The eyes are over here and the front of the brain's here. This is the back of the head with the cerebellum, spinal cord going down. Well, the old part of the brain, the limbic area, the ventral tegmental area, nucleus accumbens, this is unconscious part of the brain. Some people call it the ancient brain, the reptilian brain, but this is what keeps us alive. This is where dopamine is. The prefrontal cortex is where we stop and think about things, and they call that the new brain. And I included this just to let you know, it's actually not that simple, but in a way it is simple. So there's a lot of receptors and pathways, and we could get into all of the details. And then the other thing, there are other receptors and other neurotransmitters like GABA that are affected. And this is showing that we have cannabinoid receptors in our brains and throughout our body. And it's not as simple as some people might think. This shows the cannabinoid receptors and involved in diabetes and inflammation. So just letting you know that we are simplifying things, but this really speaks to me. So as Dr. Lemke was saying, in our brains and in our lives, it's all a balance of pleasure and pain. We want to do things that make us feel better. These are all examples of things that we do. We do them, make us feel better. And so we've got pleasure going on. It's this balance. It ends the pain. And it's been shown, this rat, and I'll show you in a minute, how much dopamine is released. To give you an idea, we kind of live at, say, 70 or so. Chocolate, we get up to 55, sex up to 100, nicotine 150. Look at amphetamine, boosts the dopamine up to 1,000. And this is actually some measurements in rats showing how much their dopamine levels went up, and they were looking at parts of their brain. So the food went up. Here they had a little female rat in there with them, and where it boosted, getting in the nucleus accumbens, amphetamines, and how it shoots up their morphine. So there is brain chemistry and research showing how this works. So, but what happens is that our brains are always trying to get to a balance. It's called homeostasis. The brains can change. We've learned that brains do change. We talked about tolerance earlier. So where does tolerance happen? The brain adapts. And so what happens is when we have so much pleasure, Dr. Lemke says these little gremlins come along and balance out the seesaw. But what happens is the brain itself is rewiring and the dopamine receptors are changing. But at some point, when there's so much dopamine going on, it gets to where the brain has adapted so much that it's more pain than it is pleasure. And if you've talked to anyone who has an addiction, eventually they'll say, I'm not using to feel good. I'm just trying to use to not feel bad. Anhedonia is a term for lack of pleasure. So when people are in an addiction and where they finally, it's not fun anymore and it's not feeling good and they're caught, but the pain is too much, so they're trying to use. And with opiates, prescribing it for pain, it has been found that opioids can induce worsening pain called opioid-induced hyperalgesia. So lack of dopamine can lead to craving. It's in survival mode. It's primal. We're going to go try to get what we need to get to feel better. Repeated use changes this is the Neuro Adaptation. So in this top brain, the red are where the dopamine receptors are. In a cocaine abuser, they've lost their dopamine receptors. because of continued use. So this is essentially their brain going to homeostasis. This is showing a normal person, but someone who's been off of meth for 1 month. You can see they still don't have their dopamine receptors as normal, but 14 months off. So this is part of why it's so hard for people to stay in recovery and why they seem to be doing so good, but they ought to be feeling better, but they're not feeling better because they don't have the means to even, go do something that would make most people feel good. They don't have the dopamine receptors. So this is one of the reasons and one of the arguments that people give for using buprenorphine or methadone, that it can stabilize dopamine while people are getting the behavioral therapy. Talking about why people relapse. So our brains are always trying to get to balance, to homeostasis, but the brains will change. If somebody keeps putting chemicals into their brain, it's going to have to adapt because it's got the extra chemicals in there. So how do we get to recovery? Definitely recovery is not a straightforward, and recovery is not straightforward if you're a diabetic or have any other chronic illness. This is good. This is from the MAT training, but it's showing that there's often a myth that people with addictions don't get better, that it's just hopeless, or they've already been to treatment and there they've been. And I think Josh told us, I don't remember if he said he'd been to six treatments or 7 or 8, but it's pretty common. But what can we do in primary care when we are working with people who don't have full-blown addiction is to be looking, there's an opportunity here for screening and working with people so they don't get too far down the continuum. I mentioned Dr. Judd Brewer. This is his book that I found. It was on the craving mind. And as I started reading this book, I was like, wow, this guy's onto something. And for me, it's onto something for me because I was been trying to be more mindful and use meditation and mindfulness. Well, these are actually 2 of his apps. And this week, I read a lot of his stuff and watched the videos, but this week I've been using his apps myself on my eating and my anxiety. And it's pretty interesting. So this would be the third thing I would say to remember. This is a way that anybody can use to deal with an addiction of any type, or just misusing things. This is from one of Dr. Brewer's, or he calls himself Dr. Judd, one of his videos. Addiction is continued use despite negative adverse consequences. So think about Facebook use, continued use despite negative consequences. People are getting in wrecks. They're not doing stuff or losing sleep. This is the dopamine molecule. So anything can cause addiction. And what he describes really well is the reward behavior loop. This is Jenny's cat. Remember Pavlov's dog. Our old brain is made to fight or flight. When something bad happens, we're going to run away. We get stressed. We don't have time to think about, is this safe? Is this a good thing? So the old brain, it's going to do what it does. And one of the things it does is it gives us a way to have lots of habits. Because if we had to think about everything every day, if we had to think about what should we wear, or how to brush our teeth, or how to, we just would be worn out. So our brain is made to make us do certain habits so that we can survive and then put our brain power to other things. So the reward behavior loop is this. There's a trigger. So this trigger is food. There's a behavior, eating, and there's a reward. So think about Pavlov's dogs. There was a bell that rang. They started salivating. And when they salivating and when they went to get the food, they got fed. And so that meant that every time they heard the bell, they're associating it. And I know, just like Jenny's cat wanting to be rubbed, that she is doing a certain behavior. So there's a trigger, a behavior, and a reward. So we do these things to feel good. We see food, or we go for a bike ride, or we do something, and something triggers to feel good. We do it, we feel good. So you've got the trigger, behavior, reward. Well, also we learn that if we have something bad happen, we do whatever we do to feel better. Eat chocolate, go smoke a cigarette, go for a run. We feel good. So this behavior loop is two ways. And actually Skinner talked about positive reinforcement and negative reinforcement. We do things to either feel good or to avoid feeling bad. And this is the scientific drawing of it, showing that we have craving, we do something, gives us a positive effect, and then it keeps it going. Or we do something and it keeps a bad thing from happening, and so that keeps loops going. So when we're in stress, our old brain is going to immediately fight, flight. It's going to do what makes us feel good. So if someone has used a substance or they've become dependent, they might intend to do right and feel better. We might go on a diet and intend to eat correctly. But when we are trying to survive, when we're stressed, when we need to feel better, that old brain, it's all about survival, and it's given us muscle memory. And this is that limbic system. Remember I said there was that book, Age of Addiction, and he talked about limbic capitalism, because our world, they have figured out how to make us addicted to things. I'm hearing my computer give me little bing, bing, bing. Well, they've done that, and every app you get, everything, they want to set notifications, because they know if they just bing you a lot, you're going to be can become addicted and subject to whatever they want. Thinking about this curve, remember what makes something more addictive? Intermittent reinforcement. And actually, if you feed the dogs every so often, and not every time the bell rings, they are going to come more often. So intermittent reinforcement is more rewarding, and also something being available right away. That, remember, smoking crack, get right to the brain, it's going to be more addictive. Thinking and planning, that's not part really of addiction, and but it needs to be part of our recovery. But sometimes it's hard to get there because our old brain just takes over. We felt good, donuts made us feel good, so we're going to do it. Whereas the training, this is where Dr. Judd Brewer is trying to teach mindfulness to help us be aware of what we're doing, and to go, hey, oh, I want a cupcake, I want a donut. Wait, I just ate. We don't take time to think and wait because our old brain is in control. It goes through some of the different ways that you can try to control yourself, but giving to, and this is the recovery tool of the day for all of us. It's useful if someone has an opioid use disorder, or if it's drinking too many Diet Cokes, or working too long. Mindfulness and being aware of what we're doing. So this is from Dr. Judd's, one of his little videos, and what he's saying is, and he did research at the VA with smokers, and had some really positive response in using functional MRIs showing the effectiveness of this type of mindfulness treatment. And you've probably heard MBSR, mindfulness-based stress reduction, is evidence-based treatment for lots of things, but especially including addictions. So this is another picture of Dr. Brewer's website with the apps that are available for anybody. They are free. And then just to remind us that mindfulness, he's not making it up. Some of our best teachers and pioneers in behavioral health integration, Dr. Kirk Strassel and Patty Robinson, here's their book on using mindfulness in this moment in behavioral health integration and how to make behavior change in primary care. Definitely Healthy Living, Whole Health Institute has given us some resources. For me, I end up using the Serenity Prayer. You know, is this something I can change? Is it not? And the autobiography in 5 chapters. But I want to end there and give us a chance to chat or to talk. but also I know we're just about out of time. But the thing I really wanted you to go away from today is to have hope. The opioid epidemic is horrible. There is a lot of death. There's a lot of corruption. It seems impossible. Helping someone with addiction seems impossible, but actually it is possible. You know, us working on ourselves one at a time and us helping one person at a time. So this is what I want to leave you with, is hope that we can make a difference. We have made a difference, and we'll continue to work together, all of us, and make a difference. So that's it for me.